Quality in healthcare is not an act, but a habit. And clinical governance ensures that safety, excellence, and accountability becomes an integral part of our daily practice. So, with this note, good evening, everyone. I am your host, Dr. Pratibha Singh, Chairperson of International Academic Exchange Committee, Fogsi, and it's my absolute pleasure to welcome you all for this 12th podcast of this month, that is Gyan Pravah series, meaning the flow of knowledge. And this initiative is the visionary brainchild of our esteemed Foxy President, Dr. Sunita Tandulwadkar, ma'am. And I sincerely thank her for this incredible opportunity because sitting across for such a legendary figure and engaging in one-on-one conversation is truly beyond imagination. And I'm deeply honored and humbled, madam. Now, it's my privilege to welcome Dr. Sunita Tandulwadkar, ma'am, who, despite assuming office just 35 days ago, has already set most of her project in motion. Her dedication is unwavering. She is committed 24/7, 365 days to the advancement of women's health and we Foxians. So hats off to you, ma'am, for your visionary leadership and relentless commitments. Now, ma'am is not only the Foxy President 2025, but she is also the President-elect of ISAR 2526. And it was an absolute treat to hear her inspiring oration at the recent ISAR conference in Lucknow. She is world-renowned IVF specialist and minimally invasive surgeon, and she has earned numerous awards and accolades. Among her extraordinary award or achievement is the India's first stem cell baby, a groundbreaking milestone, which is also the world's first stem cell baby at the age of 45 in 2018. So many things to learn from you, madam. Your guidance is truly inspiring, and I'm confidently can say that I'm loving my work under your mentorship. So, with immense gratitude, I now invite you to welcome our esteemed guest and bless this podcast. So, over to you.
Thank you. Thank you, Pratibha. Thank you for such a sweet, kind words of yours. Uh, all the viewers, good evening to you all. And I welcome you for this 15th podcast series. Gyan Pravah is our 8 p.m. every night program, which has been designed only for the committee chairpersons. We have 30 committee chairpersons, so 30 chairpersons on 30 days. And whenever there will be a 31st of that month, I'll be coming with one of the faculty. What's important is these chairpersons are working very hard for it. They use their passion, creation, intelligence, imagination, and they select the faculty so that their podcast will be the best from the rest. And to achieve that, they may take sometimes the academician or sometimes the social worker, politician, big figure, philosopher, anyone from the field, and they give 45 minutes of a fantastic one-to-one dialogue with. I felt many a times I am learning myself with each podcast, not only from my chairperson, who are the future leaders with the creativity, with the talent, with this oratory skill, with their imagination, the way they intermix and the way they come out with the beautiful podcast. Many of us learn not only from the faculty, but by this chairperson also. I love you all, and I wish everyone to join at 8 p.m. Today, we have Professor Arul Kumaran. I think there may be a fight between the UK and India to which country he belongs. So he is loved by each and every Foxian. I know by each and every gynecologist globally, but India always feel pride if Professor Arul Kumaran come even for their conference. The conference becomes larger than life. And the beauty of Sir is he don't have no word in his dictionary. At least I know for India. So thank you so much. And one more thing. I don't know whether I need to disclose this because I have not yet received, but probably soon I'm receiving the fellowship by Royal College And my whole credit or my gratitude towards Sir because he has personally taken interest in proposing it. Sir, I will be immensely lifelong grateful to you for your this very simple act. For you, it was very simple. For me, it was a golden opportunity of my life. So thank you for being there always with us. Thank you, sir.
Thank you very much. Thank you.
Thank you, madam, and congratulations, a big congratulations to you, and you really
I
deserve
could not
that.
stop that because the amount of effort sir has taken, I thought this is a platform I need to openly appreciate it.
So big congratulations to you, madam, and that party is due. So thank you, madam. Your guidance and advice will undoubtedly help us in our future endeavors. And today, I'm in conversation with one of the most respected voices in Ops and Gynae on the topic on clinical governance to improve safety and quality of care. And it's my privilege to welcome and introduce this globally renowned leader in Ops Gynae, Professor Sir Sabaratnam Arul Kumaran. Sir is a professor emeritus of Ops and Gynae at St. George's University of London. He currently serves as a founder professor of Ops and Gynae at University of Nicosia and is a visiting professor at Imperial College of London. His distinguished career include serving as a past president of FIGO, British Medical Association, and the Royal College of Ops and Gynae. A prolific academic, he has authored almost 38 books and nearly 325 research articles. His contribution to medicine has been recognized with numerous prestigious honors, which include Knight Bachelor's Award, which was awarded by the late Queen in recognition of his service to medicine, Sri Lanka Ranjana National Award, a distinguished national honor of Sri Lanka, Active Citizen Award for recognizing his contribution to society. And beyond his academic and leadership roles, Sir has been deeply involved in research and has held several high-profile positions. Notably, he was appointed as a chair of panel of inquiry into the tragic case of Savita Halapanwar in Ireland, a case that brought significant reforms in maternal health care. And we look forward to gaining his insight on this during our podcast. So, sir, it is an absolute honor to have you here. And I'm truly grateful that you accepted my invitation. And I'm proud to present you as my first guest through International Academic Exchange Committee, Fogsi. So welcome once again, sir. And before we begin, I request ma'am to share a few words. So ma'am, on you.
Sir, you are requesting sir to share a few words, sir. Please, to
Yes,
you.
sir, please.
Yes, thank you very much, Sunita, for inviting me and Pratibha for conducting this interview. I'm delighted that I have been given an opportunity. It's a rare privilege to be invited to have a one-to-one chat, and especially by esteemed Foxy and the Foxy president taking an initiative with you, Pratibha. So I hope to participate fully over the next 45 minutes or so to say whatever questions you ask, I'll try and answer. Thank you. And of course, I'm happy to discuss about the inquiry which was held in Ireland. And as you mentioned, it revolutionized the Irish law in permitting abortions to be done legally, thereby preventing 4,000 women crossing across to the England to get the abortions done. So it was sacrificed by an Indian lady life, which brought about this change, and I was partly instrumental in pushing the reforms. Thank you.
Thank you, sir. And it's honor to be in one frame with you. Pratibha, I wish you all the best for the podcast, and I'll join the viewers link. Thank you.
Thank you, madam. Thank you so much, and bye. So sir, welcome once again. And now, shall we start, sir?
Yes, please. Thank you.
So, sir, now recent years, what we have seen that healthcare system has already been improved so much. But still, many of us don't know what is this clinical governance. So my first question will be to you, sir. Sir, what is the clinical governance and how it is crucial for this modern healthcare system?
Thank you, Pratibha. So if you look at what is happening throughout the world, and especially if you look at the statistics from America, 1/3 of deaths, I am talking about all the disciplines, happens because of medical errors, because of wrong medication or too much medication, or not observing the patient carefully, or doing the wrong operation, and so on.
Yes.
When we talk about clinical governance, the background to clinical governance is to improve the safety and the quality of care. Now, safety means that not only treating the condition and curing the patient, but not to have any side effects. Like, say, if you do a cesarean section, if she then has a pulmonary embolism or a wound infection and burst abdomen, that's not a good outcome. Also, initially, there's a healthy baby and healthy mother.
Yeah.
We have to take precautions to avoid the unwanted effects from happening. That's what we call as safety of care. And this quality of care is based on the backbone of safety. So if you give good care, there are no complications due to your treatment, and the mother and baby are well, then we can build on quality, which respects on giving dignity, respect, timely care, confidentiality, and other aspects of care. So clinical governance encompasses a tool which improves safety and quality on a continual basis.
So how it is crucial, sir? I think we healthcare workers should be accountable for that, for at least giving the high quality, safe and effective care to our patients.
That is very true. So like a big hospital like St. George's, which I work, or any big hospital, a government hospital in India, there will be large number of doctors, large number of patients, large number of nurses, and so on. So it is very easy for people to miss something because they think somebody else would have done the task, or somebody else will take care of it, and so on. So we
Yeah.
had to look into 7 elements of clinical governance. It's like somebody standing in front of you and stretching your arms and legs. The head is really the part which thinks, the managerial compound, and the clinical directorship, or the head of the department trying to control. The right arm is like having enough people, doctors, nurses, midwives to work, and pharmacists, and so on. The left is actually about the space, where there are enough beds, where there are enough units, and so on. And then you build up on availability of guidelines, whether they're working according to guidelines, whether there are any training programs for them to work according to guidelines, there is any audit process, complaints, and feedback. So there are quite a number of components, about 7 components, which fits into the setup of clinical governance, and each of one of can be expanded.
Okay. So sir, this is the example you are giving, the way we should be knowing about what is the clinical governance. How can you, I mean, if you want to explain it in by giving an example, this is the way we can explain that is the clinical governance, how it works.
So the person who is in charge as a clinical director or head of department have to delegate the responsibilities, but take overall control. For example, they had to find for the total number of operations and deliveries they do, where there is enough theater space, where there are enough postnatal care. Is there an ICU if you are doing placental adherence spectrum disorders? Whether there's any blood transfusion facilities. That is one aspect. We must also make sure there are enough people who are qualified to handle each of these areas. Then we have to make sure there are guidelines available in a file form or an electronic form, which is available for them to use, and some training program, education and training programs for them to provide. So like Fogsi does all these podcast conferences to educate people, and training, hands-on training.
Yeah.
So all these components put together had to be checked if we are to improve clinical governance. That means safety and the quality of care.
So, sir, you are at the place where all advancement is there and all facilities are available. But like where we are staying, like in India, where the resources are very limited and we are working in a very limited resource settings. So what do you think, what are the real world challenges for this clinical governance, for implementing this clinical governance in our setup?
Yeah, so in place like India in a busy setup, it might be difficult because there might not be enough people. So which means they don't give enough time for each individual patient. They might be doing jobs hurriedly, taking shortcuts, and then having problems. So the first and foremost is to see how each patient's journey, when they get admitted, how do they come? Are they greeted well? Are they reassured? Are they given information about what is happening to them? And what's the treatment is explained and so on. So if every single process is taken as an individualistic view, then the clinical governance will be observed because each doctor or nurse will make sure that they don't do a wrong thing or they don't cut time and make mistakes and provide the best of care to the individual patient. So I think India has a problem of the lack of the human resources because lack of finances. And when there are lack of human resources, there are lack of time to provide the services to all women. And the lack of time, then there are more mistakes made or by taking shortcuts. And there is lack of time to provide information or communication
Yes.
and you gather with the team. So there is some difficulty, but we have to see within the given setup, how can we improve the care we can provide?
I think in our setup, what I have experienced, that people, they want to change also. There is a resistance to change. They want the way they were practicing before. There are, I mean, in the setup, like I stay in Bihar. So still the old aged ways, the way people are doing, they continue to do same type of work. So I think they have to change. Then only this clinical governance or the quality care can improve. That is what I feel, because a lot of projects have been come from government and lot of improvement is going on in our India also, and many projects from government side and even from Fogsi like Manyata and all, where they are improving the quality care of all the nurses and all. So that is also giving lot of impact on this. But I think still lot of work has to be done, and we have to promote this clinical governance and quality care. Then only I think people will understand that quality care in health is also very important, because people, they feel that once they are sick, they feel that now whatever way they will get the medication or the treatment, that is what is required. I'm not talking about the big cities in India. It is for the smaller cities and the rural areas where still all the facilities are not available and have not reached. So we have to continue giving quality care to everybody. Everybody has right to take this quality care in health. So that is what I feel like this. So, sir, thank you so much for elaborating that what are the challenges in this. And I think, do you think that our healthcare providers or healthcare workers, they should be trained enough? They should be should be given training regarding this clinical governance and quality care, because still that parameters are not set in our India. So what do you feel in your place, and what do you think that how it should be implemented in India?
So it's a very important question. That means the whole team working in a setup like a
Yes,
department should come
yes.
together. And they should really ask whether they have got enough time to have teaching and training in their process,
So
whether
I
they are.
beg your pardon. I beg your pardon. What do you feel? Quantity and quality. Like in India, it is quantity.
Yes.
So
So the
how do you think in that?
quality is important. The quantity, of course, is too much also will be a problem. So you have to tailor what is most important in terms of education and training. And the most important aspect, like the guidelines, should be available. For example, if we take a simple thing like giving steroids for babies who are going to be born preterm, then there must be an audit from time to time to see whether there is enough stock of steroids available, and also an audit about whether all the babies born preterm had steroids so that they can reduce the respiratory distress syndrome. And similarly, women with postpartum hemorrhage, whether there's enough tranexamic acid available, and also whether every single woman who had a postpartum hemorrhage had tranexamic acid. So thereby you can improve. 30% only had tranexamic acid, then that's a problem. And even a big trial like the Champion study done by WHO, they were collecting blood in the collection bag. And in 70% of women who lost more than 500 ml, they didn't get additional oxytocin. And in 30% of women, there was more than a liter of blood and they didn't get additional oxytocin. So even in big setups under trial circumstances, the appropriate care is not given. So I think it is quite important for us to think back and audit our work and see whether they had the appropriate care and simple things like tranexamic acid, steroids, IV fluids, and so on, so we can enhance the care we are given. It's like giving care to your own mother, sister, wife, whatever extreme care you will take has to be given.
Very rightly said, sir. Very rightly. This is what we require, and it has to be propagated in a proper way. That is very important. So, sir, now I want to ask, what is the impact of patients' involvement in clinical governance or healthcare outcome? How do you involve patient in this? How can you involve?
That
Uh,
is quite
yeah.
essential. If we go to the airports nowadays and all the beautiful airports in India, whether it's Mumbai, Delhi, Chennai, there is always a small machine which says whether the services has been good, whether you dislike the service, like the service, like it very much, and so on.
Mm.
Same way, there are small handheld machines which can be employed in the wards to get feedback.
Yes.
And that's the initial feedback to say whether the services they receive are good, bad, or extremely poor.
Yeah.
So you get some feedbacks, and also you can have some feedback forms where one or two patients can be given to complete the feedback forms and then give it to you so that you can concentrate on what things have been done badly, especially when there was a poor outcome. Those are the patients and relatives you should give the feedback so they can provide their own individual failings and the failures of the services which we can focus on. So feedback is quite an important one, a simple one and a complex one when things go wrong.
So definitely, sir, what you said, that feedback mechanism is very important. And also, I think engaging patient in shared decision making.
Absolutely.
Whatever, yeah, it is very important that you should share the decisions with your patient. And this can reduce medical errors, which is very common now. It's been seen. So that should not be done because everybody now expect 100%, safe. If they are going for any surgery, it should be 100% safe. So that is what I think quality care should be given to our patients. Very
Absolutely.
rightly said. And we must share our decisions to our patient, and we should, most commonly, which is what we see, that during cesarean sections or when the patient is delivering, in that time, many a times doctors, they don't exactly tell them that. Suddenly they'll say that this is a, I don't know, sir, I'm not talking about your part of world. This is in my part of world. This is what happens, that patient comes and you have to go for cesarean section, and patient, they don't understand also that whether it was required or not. So we should involve our patient for making decisions for their treatment. So thank you, sir, for this very important aspect which you have brought. And next, what I want to ask you, that now there is digitalization and artificial intelligence has come in, which has taken a lot of things in our, it has come in a big way. So how do you see that the future of this clinical governance evolving advancement with this artificial intelligence? Do you think it will going to help us, or it is just,
No,
how, how
it'll
do you
help.
think
There are
it
a
will
few
help?
aspects, Pratibha, which you just touched on about even patient information according to what they have.
Yes.
They feed it into an artificial intelligent computer in the clinics or theaters or in the wards.
Yes.
And you feed the information, and the information will be received by the artificial intelligence with a background and will give for you with this condition at this age and this problem, this might be the best option. So in other words, the patient has something on. Where currently what we have is actually patient information leaflets produced by the Royal College.
Yeah.
So if you go into the Royal College website, there is patient information leaflets which we give and the patients read it and then come and ask questions.
Yeah.
But that for some information for general everybody. But with artificial intelligence, you can feed in your individual issues. Say I'm 45, I come with heavy bleeding, I had clots, I had anemia, I had ABC. And
Yes. Mm.
that is one aspect. So it'll harness the possibility of having a good discussion for patient involvement in decision making. The
Yeah.
second is what I call as 3Ds.
Mm.
Data, digital, and devices. Data is the individual data plus collective data, which will give the possibility of harnessing what might be the best for the individual patients. That's data. Digital is entering all the information, which can be converted into useful information for the patient to take. And devices, because nowadays, even after delivery or after a surgery, there are some observations which has to be made. And that can be done by the patient if you give a small device to check the pulse, blood pressure, oxygen saturation,
Yes. Yeah.
get it even in antenatal period having a small fetal heart detector. So I think the artificial intelligence will pick it up and say, well, with this observation, you have to go somewhere. So it's not a blank observation of information, but that information converted to actionable entities. So that should be the role of artificial intelligence in the future. So it'll be incorporated into data collection, digital information, as well as devices, which will not only measure, but will also prompt what needs to be done given the background.
So I think it will streamline the documentation and will reduce the errors. That is what I feel. It
They will also prompt the patient
from the patient, yeah.
with help.
Because artificial intelligence is very new, but now everybody is on net and they can get any information from net. So that is sometimes that can give you some problems, because many a times the information which we get on net is not correct. So that correct feeding of the information is also very important. Then only, because humans and the artificial intelligence, there should not be a clash between that. That is important. That is what I feel like that, because many a times what we say, and sometimes it is not correct with the even with the net, or with the with the artificial intelligence, or with our whatever feedback we get from the net. So what do you think in that way, sir?
Yeah, I think you're right in the sense that the literature from the net gives a gross picture of a condition like endometriosis or fibroids. But with artificial intelligence, you can fit it into individual risk and prognosis. So artificial intelligence will support the human intelligence by giving additional information, and this additional information will be based on large number of cases, what happened. So the same conditions, if you put a 2 centimeter fibroid opposed to 10 centimeter fibroid, the answer should be different.
Different, yes.
It will be assisting human intelligence. So artificial intelligence should be made in such a way to assist human intelligence and to act, rather than trying to oppose the human intelligence.
So thank you so much, sir. And I'm really very happy that you have cleared so many doubts on this clinical governance. And sir, if you permit, I will divert our conversation to focus on your personal career and experience, if you permit me.
That's fine.
So it's not a compulsion. I'll be just asking few questions if you can, answer, because I'm really inquisitive about that. So can I ask, sir, to you?
Yes, please. Thank you.
Sir. So first, I just want to ask you, what inspired you to specialize in obs and gynae? Because when I saw your CV, you are FRCOG and FRCS. So you did not become a surgeon, but you are a gynecologist. So how did you thought of becoming a gynecologist?
That's quite interesting. I was interested in doing pediatrics or obstetrics. I did my diploma in child health and did pediatrics for a while, for nearly 1.5 years. then I was emotionally, it was difficult for me to see young children crying and put in a lumbar puncture or needle. I think emotion of individuals vary quite a bit. Like I'm somebody, if there is a horrible scene on the television, I rather switch it off rather than seeing it. So, so I just diverted myself to go into surgical field. So I did general surgery. That's why I did FRCS. I did it for 2 years and then did obstetrics and gynecology and found that obstetrics and gynae gives happy moments for the family.
Yes.
Most of occasionally something might go wrong, but otherwise happy. So I settled down so I could do practice medicine with gynecology and obstetrics as well as surgery. So I qualified in three, but took further interest in obstetrics and gynecology.
So very rightly, sir, even that gynae is also my passion. I also took like that because I don't want to go in any other medicine, any other branch rather than gynae. Gynae is really very, very rewarding where when you see the baby's smile and when the baby's birth and the patient and the mother and child you see, it's really, really rewarding for us. So really, really very good, sir. And we are really honored and we are really privileged that you are, I mean, you are our mentor, you are our teacher, and we have learned so much from you. Now, sir, everybody has their guru, their mentor, and so I just want to ask you, your one mentor who has significant impact on your career. Any guru, any preacher, or any teacher who has had a, I mean, you had much impact on your career.
I had many mentors, not one. As I grew and started my career, the obstetrician and gynecologist who trained me for 2.5 years was my mentor at that time. Then, of course, I joined the University of Singapore as a lecturer and worked with Professor Ratnam and worked with him for 15 years. And I think he was a true mentor for me because not only I learned the science and art of obstetrics and gynecology, but he was always emphasizing that if you want to bring about real change, then you can't do it by just practicing from morning till evening. You have to get involved in professional organizations like Fogsi or the Royal College or the FIGO and so on. So you can put your thoughts and galvanize your thoughts with others and bring about a change in some guideline, change in practice, change in helping other people and so on. So he was a mentor who dragged me into the what we would call the political arena of medicine. So I became the Royal College president of the British Medical Association and the FIGO because I wanted to do something using that organization as a vehicle, which I would not have been able to do on my own. By joining as Secretary General or then President and so on, I could say, this is what we think we should do and brought about this change. Simple like clinical governance, I brought what you call as a maternity dashboard to monitor the clinical events and like consultant on call, the responsibilities. So those changes were possible because I was in charge of an organization. So that was brought about by mentor, Professor Ratnam, with whom I worked for 15 years.
So definitely, sir, you need some mentor and that can bring some change. And really, you have entered in this profession and this organization. So you have really made it world open for everybody and so many new things you have brought. So really, really, you are honored. We all are honored to follow you the way you have done your career, your journey as a professional. So one more question I just want to ask you. What is your most memorable moment in your professional journey? Any moment which you feel that is the most memorable one?
The most memorable one is when I got a letter from the Prime Minister at that time, Gordon Brown, saying that the Queen has decided to award Knight Banneret. It's the highest award in the UK.
Yes.
People get it every 6 months, Dame for lady and Knight or Sir for men. So it was the highest award which one can get in the country. So I was from another country and coming and settling down here and being rewarded
Yeah.
for services to medicine and health sciences. I think that was memorable because that can be treasured forever. And
Yeah. Yes, sir. It is a
somebody,
great honor, sir. Yeah. So, sir, last question. If you were not a gynecologist, what other career you would have pursued?
yeah, I think thinking back, I would have insisted on doing pediatrics certainly I would have been keen to do medicine in some way as a doctor. And then I would have gone into pediatrics, which is my next favorite subject, but specialized in a little bit elderly children rather than the very young ones. And
So,
then
so
that,
medicine was in your mind since your childhood. I mean, there
med-
was nothing else, and it was clear that you have to be a doctor. That is
yeah, I
what I
want
feel.
with the service industry, shall I say,
Yes,
I know being of some interaction with humans in some
yes,
way or other.
yes, sir.
Medicine was the most highly respected. Of course, there was engineering and accountancy and other things that
Yeah,
less interaction compared to medicine. So I chose medicine.
sir. Okay, sir. And sir, yeah, I just want to ask you that any research paper that profoundly influenced you to approach this clinical governance, because this is something very, I mean, unique which you are doing. So why you have, I mean, you have researched so much in this. So what made you do that?
Well, it was in 2006, many years ago, there was a hospital in London called Northwick Park Hospital, one of the very popular hospitals, where they do 6,000 deliveries each year. And there were 10 maternal deaths in 3 years, which is unusual, about 5 times higher than the national average. So there is a quality assurance department. Well, those days we call it Healthcare Quality Commission.
Mm,
And the chair of the commission did the inquiry himself and decided that this hospital should stop the services on providing maternity care because it's dangerous for women.
mm,
So they can't shut 5,000 women from going into birth. So the ministry decided they should ask somebody to take charge of the hospital. So the minister rang me and asked me personally, saying, "Can you take charge of this and reverse the process and avoid women dying?" And to read the Kennedy report, it was called the Kennedy report because Sir Ian Kennedy was the person who wrote the report.
mm.
So when I read the report, it gave me lots of issues about the things we just spoke about clinical
Yeah.
governance. Not enough guidelines, not enough training, not enough people, not enough theaters, not enough spaces, and no discipline. And they were not looking at patient complaints and feedbacks and so on. So I thought the only way we can bring about this change is to involve clinical governance and give the responsibility to different people, one person to look into guidelines and update it, one person to look at audit, one person
Yeah.
to look at teaching and training, one person to look at complaints. And then we get together and collect information. This includes not only doctors, but midwifery staff as well. So that paper predominantly pushed me to look into medicine in a different perspective. How can we improve safety and quality? And after that, I decided I should go as president of the Royal College and contested for the post because I thought having that background, there were so many things happening and all the confidential inquiry into maternal deaths, they say 60 to 70% are suboptimal care. So I thought if I take in charge of the college for 3 years, I can bring about these changes. So that paper really impacted my mind so much. So my next 3 to 5 years was devoted in encompassing clinical governance in the institutions.
So, sir, really, really, sir, great work done. And we must follow that because it is a very good guidelines and all you have prepared, and that should be really followed. Now, one question that is any comment on that high profile case of Savita Halaparwar of Ireland, who was for which you have appointed as a chair of panel for inquiry into her death? Because it was very unfortunate the way she died. That is what when I was reading that, it was really very, very tragic.
So
So what
Savita,
is your, yes,
yeah, so Savita Alapanama was a dentist from India who married an engineer and settled down in a town called Galway. She was about 17 weeks pregnant when she had bulging membranes and went into hospital. They picked it up and managed it conservatively. And she was the reason the cervix was opening up and the membranes were ballooning was of subclinical infection. So later on, within about 24 to 48 hours, she ruptured the membranes, and then later she developed fever and high tachycardia and foul-smelling discharge. But the clinicians there were scared to offer termination because legally they are not possible unless there is a threat to maternal death. Now, it's very difficult to define when the mother is going to die or when she is going to get severe. So while they were observing, they observed because the fetal heart was present on a Doppler machine. And they said, when the fetus is alive, we can't offer termination. And suddenly the things took to the worst. As you all know, sepsis in a pregnant mother suddenly deteriorates, and she deteriorated within 8 to 10 hours of having severe tachycardia. 160, she collapsed with low blood pressure, and then she could not be resuscitated fully. She went into multi-organ failure and then died. So the inquiry was about what we could have done. So I said first, they should have offered a termination because the chance of viability is very little at 17, 18 weeks to carry on. And even after ruptured membrane, there was another opportunity. And the first white cell count showed 16,000, which nobody noticed. Then the pulse rate was high. They didn't notice. They just observed and didn't do repeat observation. They were waiting for next day to do the next observation. Then the woman, the Kalapana Savita was having chattering teeth. She was shivering, and they thought it was the cold. They didn't think it was due to sepsis, so they gave her an extra blanket instead of taking opportunity. And so they were focusing on the fetal heart sound. So I made the inquiry and gave recommendations what should be done. 3 of them were medical, about how to observe an ill patient, how to improve sepsis and manage sepsis and so on. But the 4th one, I said the law should change.
Yeah.
Legal and medical people should get together and change the law. Otherwise, these maternal deaths will happen, continue to happen. So that set the ball rolling because of my 4th recommendation. So there were people who got agitated. There was already agitation because 4,000 women used to travel across to England to have termination done. So they were all agitating for a long time, but this was an opportunity for them to highlight because this inquiry prompted a recommendation to change the law. So we had to bring about this change. So I worked with like-minded people like the Irish Family Planning Association, brought a lot of meetings. We established with the government something called Citizens Bureau with 100 people from different walks of life. Gave lectures saying if you do termination, it doesn't mean abortions and will go increase. In fact, it'll decrease because if you do medically guided abortions, then you can offer family planning at the same time. So we, after agitation, then we got them to sit down and say at what gestation would you allow for if there is incest and rape, if there is medical disorder, if it is for request, and gave some recommendation to Parliament. So I presented myself to the Parliament along with other experts. And there was a select committee, so we gave inquiry that we gave evidence. And finally, they agreed to have a referendum. And the referendum voted 66% to change the law and to permit abortion on request up to 12 weeks after seeing 2 doctors and waiting period of 3 days after the initial counseling. So it was a long process to change the law, but it changed. So it changed Ireland into a kind and considerate society for sexual and reproductive rights. That's in a nutshell what happened. And
Yeah.
as
Very, I mean, really, it was very unfortunate, but at least something has been done for the future. That is very important.
Irish television has documentaries, 2-part documentaries about Habitas Alapanava's life.
Okay. Yeah, I saw that. That is what I saw. Yeah.
That explains about what happened. So
Yeah. Yes.
gave some appearances about what happened and why I made that recommendation and so on.
Very, very effective thing you have done, sir. So that is very important, because
Yes.
life of a woman is very important. Life of anybody's life is very important. So that should be taken care of first. And sir, now we are towards our end of our podcast. So I just want to ask you, would you like to give any message for our viewers about the importance of this clinical governance? Any important message if you want to share with us?
The only message I want to give is actually if we consider every single person who is coming in front of you as your mother, sister, wife, and what is the best care you will give under the circumstances, give the same care to the patient who is in front of you. And if you're unable to give that care, you have to find out what it is, why you're unable to give the best care. And by reflecting every day, then you will be able to improve your care. So every day, think of the care you are given for the number of patients. And after all, they say in the religions, different religions say something like Hindu religions, they say about to get merit, they call it Bhakta Yoga, Jnana Yoga, and Karma Yoga. Karma Yoga is by doing things.
Yes.
So even if you have time, no time to go to the temple to pray, it doesn't matter. Because if you do your Karma Yoga, do your job,
Yeah.
attribute the credit to God, then you will get the merits. So it is not necessary to go and sit in a class or sit in a temple, but you can gain your merits in your workplace itself.
Yeah.
So that's, I think, earn your merits by doing the best service to a human being.
So I think Karma Yoga is the best which you should follow.
Which everybody should be able to do without hesitation.
Without hesitation. Yes, sir. Yes, sir. So I think prioritizing patient safety and continuous learning lead to the better outcome and more realistic healthcare system. So with this, uh, uh, we would like to wrap up our program now. So I want to extend my heartfelt thanks to our esteemed guest, Professor Arul Kumaran sir, for sharing his expertise and invaluable perspectives on improving safety and quality in healthcare. And it will surely inspire many to integrate clinical governance as a fundamental pillar in their practice. And a special thanks to all our listeners, viewers, and audiences for tuning in. And I also want to express my gratitude to Dr. Sunita Tandulwadkar, ma'am, for her vision and leadership in fostering academic discussions like these. It is through such initiatives that we continue to evaluate women's healthcare in India and beyond. Clinical governance is not just a framework, that is what Sir said. It is a commitment to continuous learning, accountability, and patient centered care. So, by embracing it, we can create a safer, more effective, and ethical healthcare environment. So, let us work together to build a culture, excellence in every aspect to our patient, our practice. So, thank you once again. And until we meet next, let's keep striving for healthier tomorrow. So, thank you so much, sir, for such wonderful podcast. And thank you so much, sir, for sparing your valuable time for this podcast. And once again, it's really, really, we all are humbled and we all are honored to be you as you were here for this podcast. Thank you, sir.
Thank you, Pratibha, and thank you, Sunita, for having me. And all the best to the viewers. Thank you.
Thank you, sir.